Welcome back, everybody, and welcome, Vikram. This is a real pleasure. I'm so thrilled that you're able to join us. This is the culmination of our celebration of World Health Day. We've been at this for the entire day, waiting for this moment that we get to reconnect. For me, of course, it's a very special privilege because not only are you the Paul Farmer Professor and Chair of Global Health and Social Medicine at the Harvard Medical School, but you, of course, are in the Department of Global Health and Population, which was my home for 23 years. This session is going to be moderated by Professor Swati Narayan. I would like to mention, though, before I turn the floor over to her, that we've had the privilege of having our good friend Sabu Padmadas from the University of Southampton here, not only today, giving a distinguished lecture, but also running a boot camp on demography for all of our students. But the main thing is, the culmination of our World Health Day today is for us to have you be our distinguished speaker, and I'm going to turn the floor over to Swati Narayan, who will moderate the session.
Thank you so much, Steve, and Professor Vikram Patel. Really delighted to have you here on World Health Day. But before I start the session, and I'm so glad to have this chance to meet you because I always speak to students about your research, and they've also already studied constituency level data on healthcare. For the students, Professor Vikram Patel is the Paul Farmer Professor and Chair of Global Health and Social Medicine in the Blatnick Institute of Department of Global Health and Social Medicine at Harvard Medical School. And Harvard Chan School of Public Health, which a lot of colleagues across the table here have a long history with. What I have particularly been fascinated in terms of your work has been the fact that you're focused both on mental health care problems, but also healthcare systems and social disadvantage and its role in the prevention and treatment of healthcare. You're also the co-founder of the Movement for Global Mental Health. And apart from several other hats that you wear, work with Sangat, an NGO in India, which has won the WHO Public Health Champion of India prize. You've also served on several government committees, and I'm hoping that today we can chat about the National Mental Health Policy. And also you serve on several Lancet commissions for reimagining India's healthcare systems. So we are absolutely delighted to have you here. And I think Jindal is also the perfect place to have this conversation, which has a very large department for psychology and mental health and behavioral sciences. But we welcome you to the School of Public Health, and we'd love to hear from you, after which we'll have a session of question and answers with the students. Welcome.
Well, thank you, Dr. Narayan. Let me, I have a presentation which I will show now. It's a real pleasure to be with all of you. I can see some familiar faces and also many new ones. I wish I was there with you in person, but right now I am in Boston, and it's an early morning in Boston as well, and it's wonderful to celebrate World Health Day with all of you right at the start of my work week. So I'm just going to share screen. I just want to confirm that you can hear me clearly.
Very well. Very well.
Okay, great. And you can also now see my screen?
Yes.
Okay, great. So, I'm going to be focusing primarily on the situation for mental health care systems in India, because this is a country in which I've spent most of my academic work and academic life. And I wanted to start by, referring to the National Mental Health Survey that was commissioned by the Ministry of Health and Family Welfare, and that reported the largest survey of the mental health of adults in India that's ever been conducted. More than 30,000 adults were surveyed in a representative sample from across the country. It reported that roughly about 1 in 10 adult Indians is currently living with one or another type of diagnosable mental health condition. But what was really, which, you could do the math, it translates into more than 100 million people in the country living with a mental health condition. These are the government's own data. But what was really important in these numbers was not just the total number of people who were affected, but the fact that these problems are inequitably distributed in the population. That is to say, people living in conditions of poverty or social disadvantage are much more likely to bear the burden of mental health conditions. You can see on this slide the relationship between the prevalence of depression and income quintiles. And it's very clear what this chart is showing us, a gradual decline in the prevalence the richer you are. And the other staggering number was the fact that about 85% of people with mental health conditions diagnosed in this survey had not received any care from the healthcare system. This is a staggering number, even more staggering when you consider that 3/4 of people with the most severe forms of mental health conditions, such as schizophrenia, had received no care at all. I think it probably is fair to say that no other health condition in the country has such high levels of unmet needs for care. Another separate piece of data, which comes from another source, is to do with the life course epidemiology of mental health conditions. And a key point here to make is that most mental health conditions begin before the age of 25. This is really a very important characteristic of mental health problems that distinguishes it from other non-communicable diseases. Consider, for example, diabetes or heart disease, which we hear a lot about in India. These typically strike you in your 40s and upwards. But mental health conditions strike you in your adolescence and youth, which is, of course, the part of your life course in which you are expected to complete many important life transitions, in particular in relationship to education, employment, and the establishment of intimate relationships. And so you can imagine that a mental health condition striking you at this stage of your life is likely to have lifelong consequences. Now, the barriers to care are many. I think we're all pretty familiar with that. I really want to focus on solutions in this talk. But just to remind ourselves, we often think of barriers to care as being primarily supply side. These are the things that we're familiar with from a health system perspective. We don't have enough qualified or skilled providers for healthcare interventions. But there's also a demand side one, which is particularly relevant for mental health, and that is related to the stigma that is associated with seeking mental health care, particularly in the context of our history, which is that most mental health care in India was always associated with mental hospitals or asylums. And these were places where you were typically incarcerated behind high walls, behind locked doors, and where some of the most egregious abuses of human rights have taken place. And this is, of course, the dominant image of what mental health care looks like. The word mental illness is equivalent in many Indian languages to madness. And so if you consider all of these historical and cultural contexts, you realize that very few people would voluntarily be comfortable to seek mental health care in the country. A couple of years ago, the editor of The Lancet invited me to put together a group of people that could examine the body of evidence from mental health research, particularly in low resource settings, to identify what might be the paradigm shifts and the related policy recommendations that could serve to transform mental health systems globally. We looked at the evidence that was gathered through a number of different reports that had been published in the last 5 years, such as, for example, the World Mental Health Report from the WHO, as well as 3 Lancet commissions that have been published since 2018, 2 of which I led. And we put all of this together and identified 5 key paradigm shifts covering everything from prevention right through to recovery. I want to focus on just 2 of those paradigm shifts today in the interest of time. And the first one, and these are relating directly to the provision of care for people who are living with a mental health problem or experiencing distress related to their mental health. The first is a paradigm shift from a narrow focus on biomedical interventions delivered for severe or acute presentations or crises to one that recognizes that mental health problems are on a dimension. And what we need to have is a stage model. You know, those of you who work in cancer care will immediately recognize this word. It comes from oncology. The idea that cancers don't suddenly appear overnight. They basically evolve over years in some instances. And the staging model explicitly acknowledges this evolution of mental illness over time and therefore opens the door for the delivery of a much wider range of interventions as early as possible in the evolution of the problem. And relatedly to a second paradigm shift from a focus on highly trained and expensive mental health specialists to deliver care to a much more diverse workforce that embraces frontline providers of a variety of types, from lay counselors and lay people themselves to peer support workers, etc., to enhance access to care and deliver these interventions. Now, the NGO that I have been associated with as a co-founder of in 1996, which is headquartered in Goa, but now has large presence in many states of the country, including hubs in New Delhi and in Bhopal, is easily the pioneer in India and I would argue probably in the global context in designing and running the large randomized controlled trials that establish the effectiveness of this approach. That is to say, psychosocial interventions that are being delivered for either the prevention or care of mental health problems in routine care settings. Importantly, these interventions are designed for delivery by non-specialist or frontline providers. Here you can just see a snapshot of the many different randomized controlled trials that Sangat has led, which cover every mental health condition from autism and schizophrenia through to depression and drinking problems, and cover both the prevention of those problems, the treatment of those problems, and supporting the recovery from enduring and disabling conditions. One example that I think has really been most an exemplary one in terms of the impact of this work is the design and delivery of a brief 6-session treatment for severe depression based on of course, this is a school of psychology, and this is particularly relevant to your students. This treatment is designed on the basis of a very, well-established cognitive behavioral technique called behavioral activation. I won't go into any detail of this, but sufficient to say is that this intervention was evaluated in a large randomized controlled trial. The findings have been published in the leading journals, but I wanted to show you a video that shows how the intervention was delivered and the experience of our participants. I'm going to unshare the screen now so I can turn on the video sound so we can all hear it. Give me a moment.
खूप त्रास आहे 2 वर्ष झाली तकली दुखा आणि चक्कर येल्यासारखीच डेली तकली दुखा डेली घरातले कसले काम जायना जाय भिजून राहा दिसभर भुरग्यांक सुद्दां लागी घेयना जाय कित्याक घरातले करिना जाय
म्हाका खूब त्रास करता घरा देव आनी तेजी बायलूय शिकयता आनी म्हाका खूब टेंशन जाता तकली आनी हांव बरें नासता म्हाका जेवपाची बी याद उरना आनी कितें खावचें कितें काम करचें अशें म्हाका दिसत ना आनी भुरग्यांकूय हांव केन्नाच सारकें वाडिनाशिल्लें कांय करिनाशिल्लें तांकां एक कितें करप आनी कितें घातलें आनी घालप आनी टायमूच म्हाका असो बसोनूच हांवें काडप म्हाका खूब टेंशन जाता.
With depression, we've developed a very specific treatment called the Healthy Activity Program. This is a treatment that's based on the concept that when people become depressed, they stop doing activities that they typically do. For example, there may be social withdrawal, they may not be able to keep up with their work demands, they may stop doing pleasurable activities like watching TV, reading, etc. The less they do, the worse they're likely to feel. So the Healthy Activity Program is delivered over about 6 to 8 sessions. So the main focus of the initial sessions is to get patients to become activated, to start doing things that we know will help them feel better.
कितें काम कर म्हणजे मागीर थंय रोंपो लायलो मातशें अशें भोंवंक वचूंक लागलें जावं काटयां हाडूंक लागलें शेतान मातशें वचोंक लागलें आनी कितें भाजी पालो घरा कडेन रोवंक लागलें आनी तितून मात मागीर म्हाका म्हयन्यान करून म्हाका एक 9 म्हयन्यांनी सारकें पूर्ण तकली म्हाजी शांत बरी जाली.
पयलीं तेणी 5 मिनटां कुळेकारां वचून काम कर म्हणलें. मागीर तेणी म्हाका 10 मिनटां दिलीं. मागीर 15 मिनटां दिलीं. मागीर म्हाका तें काम बरें जाता अशें दिसलें. हांवें 5 मिनटां 2 मिनटां वाडोवन करप. मागीर म्हाजी भुरगीं येतालीं मदत करून आनी इतल्यान म्हाजें आतां कुळेकार निव्वळ आसा आनी म्हाजी कामां चालू बरीं जाता आनी म्हाका आतां वखद सुद्दां नाका. बरी जाली तितूंतल्यान आनी बरी आसा हांव सामकी.
आनी आतां म्हाका खूब बरें दिसता. जशी तकली जास्त दुखना केन्ना अशें चुकोन दुखता. जीन उठपाचें भुरग्यांक शाळेक धाडपाचें जाता त्रास जाय. तकली बी दुखना आदल्या सारकी.
And so what you can see on this slide is the findings of our randomized controlled trial. 500 patients with severe depression were recruited in primary healthcare settings, and lay people delivered the treatment. What you can see here is the remission rates after 3 months. 2/3 of these individuals, mind you, with the most severe forms of depression, had remitted. The same 2/3 stayed well a year later, and 5 years later, the team from JPAL, led by Abhijit Banerjee, followed up these cohorts and continued to show that 5 years later, these individuals had stayed well. Two messages on this slide. First of all, 2/3 of people with the most severe form of depression recovered and stayed well for 5 years in response to a 6-session treatment delivered by a layperson. But the second important point to make is that 1/3 did not. And this clearly shows that a one-size-fits-all approach should not be thought through for mental health problems. Given the dimensional nature of mental health problems, we should be really thinking about a stepped care approach where people receive a low-intensity treatment, such as the one that I'm just showing you, but recognize that about a certain small minority of these individuals will need more specialized care. So collaborative care in a stepped approach is one of the very important messages that arises from this work. This body of evidence that Sangat has been pioneering in India has, of course, also had its analogs in many other parts of the world. In fact, the body of evidence is so strong that today, even wealthy countries are embracing the idea, wealthy countries which are much better resourced with mental health professionals, that we are able to deliver psychosocial interventions in the hands of appropriately trained and supervised frontline providers. And it's really important that these interventions themselves are designed in a way that are grounded in theory and that they have been demonstrated to work in empirically informed randomized controlled trials. Here's one example of a trial that has recently been completed in North America, funded by PCORI in Canada and 2 centers in the US, in Chicago and UNC Chapel Hill. Now, here's the interesting thing. The treatment that was evaluated in this instance for depression in mothers is the same treatment that was designed in India, making this perhaps a pretty unusual example of an Indian innovation being exported to the US and Canada. And in this very large trial, one of the largest psychotherapy trials ever conducted in the world, the comparisons were actually even more dramatic, because in India we compared the healthy activity program to usual care, which is, honestly, pretty much no care at all. But in this context, the healthy activity program adapted for perinatal depression was evaluated in 2 different modalities of delivery, comparing in-person versus telemedicine, and comparing specialists, that is psychologists or psychiatrists, versus non-specialists, which in this instance was doulas, which is like traditional midwives and nurses. The findings were published just a couple of weeks ago in a major paper in Nature Medicine. And what it showed was that the delivery of BA led to the remission of 75% of women with depression. But most importantly, there was no difference in the remission rates between the treatment being delivered by psychologists and psychiatrists on the one hand compared to non-specialists on the other. And these findings have now been embraced already by many governments in North America, provincial and state governments, and conversations are now happening on how we can scale this approach up. Ultimately, what this body of evidence allowed us to do is redefine mental health care in 4 ways. First, what comprises mental health care? We're no longer just narrowly restricted by biomedical interventions delivered in hospital settings, but psychosocial interventions, brief interventions that are delivered where people are rather than where the providers are based, delivered by anyone in the community or healthcare system with appropriate training and supervision, and delivered in a collaborative care framework with support from specialists, especially for supervision, quality assurance, and provision of referral services. This is a kind of an infographic that we produced for the Lancet, which shows really how that might look, such that you have people in the community with mental health problems who are supported by appropriately trained frontline workers. And these frontline workers, in turn, are being supported either at primary care by prescribers who need occasionally to prescribe medication and provide specialist support services, as well as for more serious mental illness through district hospitals of the National Mental Health Program, for example, where psychiatrists can support, particularly in the context of serious mental illness. Now, looking ahead, and I'm going to round up now, looking ahead, the key message from all of this large body of science, a lot of it which has come from South Asia, is the need now to refocus our attention, not on building only the specialist workforce, which of course we continue to have a need for, but to actually dramatically and rapidly build the capacity of frontline workers, such as the ASHAs, the community health officers, the ANMs, the Anganwadi workers, the whole range of frontline workers who already exist in India and indeed globally in order to deliver these evidence-based psychosocial interventions. With that in mind, 5 years ago at Harvard Medical School and in Sangat, we set up the Empower program, which is using a suite of digital techniques, procedures, and tools for enabling frontline workers to learn, master, and deliver quality-assured psychosocial interventions. This shows you an infographic of how, on the Empower platform, a frontline worker can first learn a new intervention, such as, for example, the Healthy Activity Program, can then engage in case-based practice so that they master what they have learned, what we call an intern, to then complete a competency assessment, testing their skills so that they can be certified or credentialed. And then, as they deliver the intervention as part of the workforce, over time, they become more and more skilled and ultimately become an expert who can then supervise and mentor the next generation of providers. We use technologies in a variety of different ways. The most obvious way is digitally designed curricula, which can be delivered entirely in video format, including offline. Digitally delivered skills assessments, asynchronous and synchronous versions, digitally delivered versions of apps that can be used for quality assurance. And we're currently also beginning to use large language models that can, in automated ways, transcribe and interpret the quality of a therapy session, and data-driven evaluations that link providers' data with clinical outcomes, which allow us to unpack which elements of a psychotherapeutic interaction is predicting clinical outcomes. At the moment, our programs in India and the US have already either completed or in an advanced stage of developing the curricula for depression, which is the Healthy Activity Program, a step care intervention for emotional disorders in adolescents, peer support interventions for people living with enduring mental illness, a parent-mediated intervention for autism spectrum disorder, and a single session intervention for people who've experienced peritraumatic events. The Healthy Activity Program is being scaled up through the Empower platform in the state of Madhya Pradesh in partnership that Sangat has with the state government. And incredibly, we are also now scaling up the same intervention adapted for the United States in the state of Texas through a range of different partnerships, including, most excitingly, with the Congregational Collective, which is a coalition of churches in the San Antonio region of Texas. Churches have a very important place in American life, and the congregations are highly committed and motivated individuals who seek to serve their community members. And we're really leveraging this motivation to actually engage frontline members of these congregations to become mental health care providers. So to conclude, the majority of persons with mental health problems do not receive high quality evidence-based care. And this is true even in places like the United States, which are the best resourced parts of the world. Innovative clinical and implementation science, clinical in the form of the redesign of psychosocial interventions, so they're very brief but retain their effectiveness through a focus on active ingredients, and implementation science that is examining how these interventions can be delivered through appropriately designed training and supervision, point to a radically different approach to prevention and care. What we now need to be thinking about as we go forward in terms of policy and practice is how we scale up these interventions in a collaborative care framework. And of course, the digital platforms offer a real opportunity for us to fast track the scale up. And what's really exciting is that this strategy relies for the most part on resources that every community already has, people who care for others. So thank you very much, and I'm going to hand it back to the chair.
Thank you so much, Professor Patel, and it could not have been more timely for one of our students who is doing her research on perinatal depression and the role of frontline workers. So your lecture was not only extremely apt, I'm sure many of the students have a lot of questions, but if I could take the prerogative as the chair and ask you the first one. So India is one of the countries which on the World Happiness Index is ranked amongst the lowest, and a country with high levels of poverty. So with high levels of poverty and also extremely low levels of social mobility. So what I was wondering is, yes, there could be digital interventions and frontline workers could be at the forefront of delivering mental health care, but what else do you think is the main lacunae in the mental health care law, which I feel does not, apart from saying appropriate government, doesn't seem to either offer responsibility or budgets to invest in mental health care in this country. So how do you think that could be resolved? Is it a lack of political will or something else?
So, let me first, there are two parts to your question. First of all, I want to answer. The first is about the World Happiness Report and the construct of happiness and well-being. It's really important to remember that that's not a biomedical construct. Happiness or well-being are actually constructs that span economics, anthropology, health, and a range of other, I would say, much more sustainable development-oriented concepts. So, for example, when happiness is being measured, if you look at the different ingredients that generate the happiness index, they include very important social and economic determinants, for example, education. So it's really important that this is not a mental health construct, even though the word happiness makes it sound that it's an emotional concept. Actually, it's not. And it's problematic for that reason. It really is de facto, a human development index. You'll find, in fact, the same countries that rank high on the World Happiness Report are the same ones that rank high on the Human Development Index. So it's more of a replica with slight small differences. But I would not consider that primarily a measure of mental health of the population. Of course, mental health contributes to it, but it's only a small part of that. To your point about why, what are the kind of potential barriers towards embracing alternative approaches to mental health care? I think they are the same barriers to the broader healthcare system, actually. And that is a political economy that we have to understand that of how healthcare is delivered in India. The first, of course, very important issue is vested interests. when you build a system in which there is a huge allocation of resources to physicians and for hospitals and for biomedical interventions, any kind of rebalancing to be more community focused, to be focused on psychosocial interventions, is going to face resistance. And you have to therefore embrace the notion that no reform is going to occur unless you have strong political will to address those vested interests. And this requires not just science, it requires a lot more than that. One great example of how India did, in fact, address vested interests, which means it is possible to do so, even in India with all its incredibly diverse and very fragmented healthcare system, is the ASHA. To me, I always, describe the ASHA as the most radical experiment in India's health history, because when the ASHA was brought into place, she was a worker who was going to upend the idea that you needed an obstetrician or a neonatologist in every single district of India, because there weren't any. But simply having a frontline worker who could support women through their pregnancy and childbirth could lead to a reduction in neonatal and maternal mortality. And today, I would argue that India's gains in maternal and newborn mortality is almost entirely because of the ASHA, as opposed to any kind of biomedical intervention. So, radical changes do happen in India. And the story of the ASHA is a great one for students of public health to understand what are the things we need to reform healthcare systems. And we have to embrace that for mental health care too.
Thank you. Now I'll throw the floor. That was a really insightful answer. And I'll throw the floor open to other questions that anyone in the room has. Yeah, Priyamvada.
So first of all, hello, sir. We were actually taught a course by Abdul sir previous semester on global mental health. So during that, we read a lot of your work. So sir, my question is that, so I'm interested in particularly geriatric mental health. So I've been looking up and reading up about it. My question is more just something that I want to know what you think about, since we're being taught demography right now, and we know how the population structure of the world is going to change. So I think there's a real opportunity in addressing the geriatric mental health needs that are often maybe neglected or misunderstood. So I just want to know what are your understanding on the topic and what work has been done.
So, that's a very important future priority of this country. I mean, not just aging, which is, of course, happening across the world, but also the fact that social support systems are also changing very rapidly as the size of the family reduces. This is something that happened in North America and Europe over 100 years. It's happening in India over maybe a few decades. And of course, in India, there is virtually no a system that the state puts into place for supporting older people with any form of frailty or disability. By the way, mental health in old age is deeply interconnected with physical health, particularly in old age, and these are not separate domains. So you really need to be thinking about the well-being of older adults through the framework of disability. I find that much more helpful to the framework of impairments and disabilities, because these are the things that really affect their quality of life. Impairments like, for example, sensory impairments, hearing impairment being one very good example, mobility impairments, impairments to do with their continence, and so on and so forth. And the World Health Organization, of course, has an excellent resource on impairment-based care for the elderly. What we desperately need is a body of work that demonstrates how we can support older people living in the community, because the last thing India needs is to replicate old age nursing homes that are not only incredibly expensive ways to support older adults, but also places where, given our history of institutions, are also places where, in fact, we're going to see terrible violations of basic human rights. So we really need to be focusing on community-based support. So much of what I described a little earlier is a similar platform, but the interventions will obviously be very different. They will, interventions for sensory impairments, continence, and mobility will obviously have to be very specific to those impairments. And I would encourage you to start thinking about how you can actually provide care across these different impairments rather than focusing on just the one. And I think the WHO's ICOPE program is the one I was referring to earlier, would be a great resource for you to sort of look at and consider how that might be applied in the Indian context.
Thank you.
Thanks. Are there any other questions? Oh, many. Let's do Manya and then the other side.
Hi, sir. What you are trying to do in Goa with ASHA workers and lay health workers related to community-based intervention, psychosocial health, and improving the psychosocial health of mothers, and also in that same process of people and their child. So I'm doing something similar for my dissertation, for my thesis. And in Delhi with ASHA workers, I'm trying to see if they do have the training or they do have the capacity to actually take up this kind of work of providing some sort of care or support to pregnant women during their entire pregnancy period and even after that. But whenever I actually express this idea, the one thing that I get, like as a comment or as a criticism, is that ASHA workers are already underpaid and overworked. And this is the case with every community health worker. So what do you suggest? Like, what are your opinions on that? Is it good to actually put that kind of work on ASHAs, or is there something else, some other workforce that should be built specifically for that?
Yeah, that's a great question. And in fact, what your experience is exactly right. So a couple of things to say. First of all, ASHAs are volunteers according to, the healthcare system. So they can choose to do whatever they want and not do things they don't want to do. Secondly, they're paid on the basis of what they do. So they're not paid salaries like anyone else in the health system. So as you know, if they have time and they want to do more work, it's a voluntary thing. So that's it's not like they're forced to do anything. They get paid for what they do. The second is that actually they should be fully salaried. So, I am leading the Lancet Commission on Reimagining India's Healthcare System, which should be published, later this year. And one of the recommendations is to actually give ASHAs the full rights that anyone else in the health system has. They are by far and away probably the most trusted person in the healthcare system. And it is a travesty, really, that the most trusted person is the person who is also the most vulnerable. And of course, gender plays a very central role in this. If ASHAs were men, I can assure you that they would not be volunteers. And so there are many complex issues here that we have to grapple with. And the way ASHAs are being treated is certainly one of the most one of the things we need to fix in our healthcare system. But there are other cadres now of healthcare frontline providers. The best example are community health officers. This is another radical example of a completely new human resource, just like the ASHA that was invented, about 25 years ago. The CHO is only about the last 7 or 8 years. Unlike the ASHA, though, the CHO is a fully salaried, full-time worker, placed in every health and wellness center, which are sub-centers of the PHC system. In Madhya Pradesh alone, where we have a big scale-up happening, more than 10,000 CHOs have been actually employed in the last couple of years. And the CHOs are very similar in the sense they're not MBBS. They're usually nurses or Ayush graduates who have now become in charge of sub-centers. And if you look at the set of activities that they are supposed to do, mental health is one of them, alongside many other areas focused on health promotion and prevention. So that's another cadre. And for maternal health, I will also say in particular, you should also examine ANMs and Anganwadi workers, who are also a full-time paid resource, although from different ministries. And that's another resource we use a lot. A lot of our work on early child development is through the Anganwadis, because that's, of course, where mothers of young babies are most likely to be visiting regularly for a variety of different services.
Thank you, sir.
Thanks. Yes, many of us are working on ensuring that the Anganwadi workers who are unionized are recognized as workers. Any other questions from that side of the room?
Particularly young women and their families engage with mental health services. So what has been that? Has that changed over time, and is that changing? And yeah, so particularly from gender and culture.
So definitely, Nandita, there has been a dramatic change in my own career. You know, I started working in 1996 in the sector when it was extremely peripheral, marginal. No one cared, either at policy level. It was seen as a total, low priority issue. And nobody in the community would ever say they had a mental health problem. I mean, there's been a dramatic transformation. I mean, in every respect, in every sector, from, Prime Minister of the country speaking about mental health in his radio shows, all the way through to the fact that when you have people coming to the clinic, like in all my trials, speaking about mental health. We're just running a randomized controlled trial right now, precision medicine trial in Bhopal, which is one of our most vibrant hubs for in Madhya Pradesh. We have a very strong 15-year history of collaborating with the National Health Mission, and through that we've established a large research program that spans the whole state. But one of those trials is the largest precision medicine trial of depression care in the world right now, which is comparing the healthy activity program with antidepressant medication. And what's remarkable is the number of people that we're able to recruit with depression who are utterly and totally engaged with the trial and with the treatment. These are all public primary healthcare centers. That the people who go to the public primary healthcare centers tend to be the low-income sections of our population. It is staggering how many people there are who want to be treated. So it's by no means 30 years ago, to get anyone to participate in a mental health trial would have been pretty difficult. Today, it's like exactly the opposite. We have to actually stop people because there's so many who want to be in the program. So I do think there's been a huge shift. I think in my experience, I haven't worked in every culture of the country, but certainly all the places I've worked in, I see a similar trend. And in terms of gender, I would say it's, again, something I'm very surprised about in our trial in Bhopal. Men are as frequent, it's always been the case that women have more of are more likely to experience mood and anxiety problems, and are actually quite more likely also to seek care or engage with it. But in Bhopal, we've discovered the same is true for men as well. So I see fewer gender differences than I used to see, in the past, and that's mainly being driven by men, actually, who appear to be much more open towards mental health issues and mental health care.
We have a question from Professor Savan.
Yeah, thank you, Vikram. I think that was very inspiring and very enlightening presentation. Thank you very much. My question is very simple. I think you mentioned about the onset of people being identified with some symptoms of depression or anxiety. So, one of the biggest challenges that we have is to estimate all these at the population level. Population, as it has always been referred to, is always at the tip of the iceberg. We don't know the amount that is beneath. But the question is, actually, among those who are actually identified quite early, what kind of there are interventions, but do we also monitor in terms of their exposure to other substance abuse and so on? Because today's world has changed completely. Young people, especially in India, have access to different types of drugs and so on. And of course, the family environment is also changing. From kind of a nuclear households, both parents working and so on. So, have you explored those aspects in your research?
Yeah, so I don't know. I'm not sure. I couldn't hear you very clearly, but I think you're asking about the different features, the different pathways or drivers of mental health in young people and in earlier life. I don't know if that's the question.
Yes, that's correct. And also the
onset. Okay.
So Sorry. Also,
No,
the onset of these, I mean, you mentioned that the age at onset is actually decreasing over time. That was also the question. Thank you.
Yeah, so I don't know. We can say the age of onset is decreasing. We don't have that kind of temporal data to say that. But what is very clear, without any doubt, is that 2/3 or up to 3/4 of all the morbidity that you see at a population level has its onset before the age of 24. So this is a young person's health condition. There are two implications of this. The first implication is that clearly the drivers of mental health problems, even though when we see a 35 or 40-year-old with depression, you think it's contemporary, but actually the drivers actually probably were when that individual was 13, 14, or even younger. So that's the first important point, is that these are life course conditions in the sense that disadvantages and protective factors are interacting with each other across the life course. And because the brain is most plastic, and because it has a very unique changes in architecture and function in adolescence, it's the first 15 years of life in which social environments play the most profound role in shaping our mental health. This is a very important fundamental discovery that has happened over the last 3 decades. And it's really a triangulation of epidemiological evidence. The epidemiological evidence that shows that adversities in childhood are the single most important predictor of poor mental health in adulthood, but also neuroscience. Fundamental neuroscience, basic neuroscience, which clearly shows that the architecture of the brain is laid down in the first 2 decades of life, and that process of laying down the architecture is through the interaction of the brain with the environment. And the second implication of this science is therefore prevention has to begin in early life. Prevention cannot begin at the age of 30. You already missed the boat. Prevention is about strengthening, nurturing environments in the first 15 years of life. Those environments are the environments in which children and adolescents find themselves in. That is to say, home environments, school environments, and neighborhood environments. This is the most important message of that issue about mental health problems arising in early in life, is that prevention also must begin early in life. And the lag period for the benefits will therefore also be long. In the sense, if you invest in early childhood now, you will see the benefits at a population level sometimes 15 to 20 years later.
Thank you, sir, for such a wonderful presentation. So there are actually like 2 questions that I want to ask. So one is being like, what scale are we looking at when we speak about the drug trial and application of giving of the drugs to a lot of people in India?
Sorry, I didn't get your question. Could you say it again?
So what population, because we know that mental health burden is a lot in India already, existing. And we are speaking about drug trials and everything. So what scale are we speaking about? Scale.
What drugs?
For mental health related, like for anxiety, depression and everything. Yeah.
She's speaking of the trials.
So I don't actually work with drugs myself, in the sense I mostly work with psychosocial interventions. So is your question about a concern about drugs? What exactly is the question about?
So it was a following up question, like after Nandita ma'am asked. So it was also, I'm trying to understand about the drug dependence, and with respect to AMR and other things, we have drug resistance and a lot of drugs being banned. So when we are speaking about protocols with respect to drugs and scalability of drugs and dependence on psychotropic drugs, so how is it gonna create a sustainable environment with respect to mental health?
Yeah, well, I guess, there's many things in your question. But basically, psychiatric drugs are actually not being overused in India, they're being underused. The vast majority of people with psychosis who actually can benefit from medication, like people with bipolar disorder or schizophrenia, are actually not receiving it. So I think it's not, we have a very bizarre situation in India. Depending on how much you can pay, you can either get, quality of care is bad across the social spectrum. If you have a lot of money, you get unnecessary treatment. And if you don't have enough money, you don't get the treatment you actually need. So we have the best of, or rather the worst of both worlds. Poor quality across the spectrum. Our work on the India Health, for the Lancet Commission on India demonstrates that actually today the problem in India is not access to drugs. The problem in India today is inequitable access to drugs, and therefore the irrational use of drugs at one end of the spectrum, and the fact that you're not getting the drugs you need at the other end of the spectrum. And that is, of course, a really significant driver of also out-of-pocket expenditure. The other part of your question is about drugs of dependence, which is completely different. That's not biomedical drugs. Those are, of course, narcotic drugs. This is also an issue which is highly, the distribution is very, very different in different parts of the country. But by far and away, the most common drug in India today is tobacco. Actually, it's not a narcotic drug, and most of that tobacco is, of course, chewed tobacco, it's oral tobacco or smokeless tobacco. So, again, I would say the drug dependence issue is highly local in certain parts of the country, like Punjab and the Northeast. But on a general population level, I would say tobacco and alcohol are the two substances which probably, from a public health perspective, we need to be most concerned about.
Thanks. And we have the last question from Professor Indranil.
Yeah. Thanks. Professor Patel, it was like always, it's a very thought-provoking intervention from your side. Thank you. I'm Indranil. While we are looking at national mental health policy, we consistently notice that there is very little investment as part of NHM under the mental health component, and also huge underutilization of funds. So what are your insights on this? Have you engaged with the process, the National Mental Health Plan, and what are the bottlenecks and challenges that you perceive, and you suggest that this could be overcome to have greater access of mental health care among rural communities through the public system?
Yeah, that's a paradox, isn't it? That not only do we spend less, but we also not only do we give less money that we should, but we also spend less. So we actually return money, and so that clearly goes against the whole idea that we need to be giving more money. Because if the money, even the money that we're currently allocating to certain health buckets, and mental health is definitely a good example, is being unspent, and to me, that's a real signal of absorptive capacity challenges when it comes to mental health. And the reason is that even though at the federal level, at the central level, there have been very important policy reforms, the problem in India, as you know well, is that by the time those policies get to the front line, there is actually a huge set of capacity issues that actually come in the way of those policies being enacted right down to the district level. And so, for example, even though the National Mental Health Policy, of which I was a member of the drafting committee, and the the Mental Health Care Act actually speak very strongly about community-focused, community-delivered, frontline worker-supported care, no district in the country has been able to implement it. And the reason is, by the time, you have to build capacity at district level. Districts need both public health management capacity as well as the capacity of training and supporting frontline workers to deliver interventions, the capacity of these workers, as we heard from one of the other people who asked me a question in the room there, that they have to have the capacity, the time, and the skills. So I think this is a process. And in part, what Empower is seeking to do is to actually enable that to happen by, as I mentioned earlier, creating platforms through which you can rapidly skill up frontline workers to deliver care. And then, of course, one hopes that the resources that are not being currently utilized can actually be allocated to those goals. But it's a process, and we're at the moment in the middle of that process in some parts of the country where we're currently working.
Thank you so much, Professor Patel. And I'm hoping that if not at a national level, we can work with individual state governments to expand the work on mental health care as we also struggle for the right to health care overall. Lastly, perhaps to conclude this session at a personal level, I would just like to raise that there is a very interesting article of all the magazines actually in The Economist, which says that many mental health conditions could have bodily triggers. And I do hope that the next avenue of research, of cutting-edge research on the brain actually is related to autoimmune diseases. And that in India, not only do we have we ensure that mental health care is scaled up to frontline workers, but also in the United States or industrialized countries, you have the best brain research to power ahead our next generation. So thank you very much for a lovely talk on World Health Day.
Thank you very much, and thank you so much, and I wish you all a wonderful rest of your day and rest of your function. Thank you.
Thank you.
Thank you very much, Vikram. This has been very special for all of us, and I hope this is one of several occasions and multiple occasions we'll have to interact with you in the future in our school. As you can see, many of us take inspiration from who you are and what you do.
Thank you, Stephen. Thank you so much.
Okay, see you soon.
Bye-bye.
Bye.